Good afternoon and welcome to the Brain Conference, the Nerve and Neuropathy session. I'm Mary Reilly. I'm from the National Hospital of Neurology, Queen Square, London, and I'd like to introduce my co-chair, David Bennett, from the University of Oxford. And we're delighted to have a very exciting session covering a teaching course, a basic science talk, and a clinical talk, and some data blitz as well. So with no further ado, I'll introduce the first talk. But before that, please, we'd welcome questions. Feel free to put them in the chat and we'll try to answer as many of them as we can. So the first talk is by Michael Lunn, who is a professor of neurology in Queen Square, London, and is going to talk about approach to neuropathy and paraproteins. Thank you.
Hello, my name is Michael Lunn, Professor of Neurology at the National Hospital for Neurology and Neurosurgery, clinical lead in neuroimmunology, and I also work for Cochrane Neuromuscular. Thank you very much to the organisers of the Brain Conference for asking me to give this talk entitled An Approach to Neuropathy and Paraproteins, which is the teaching part of this section of the conference. Here are my disclosures. So before we start talking about paraproteins and neuropathies, I just thought I'd introduce how I got to where I am today. I approached Richard Hughes in 1995, asking him about doing a PhD, and he directed me towards looking at antibodies in peripheral neuropathies, starting with the IgM anti-MAG antibodies in classical paraproteinic neuropathy. I did much of that work at Guy's Hospital and also quite a lot at Johns Hopkins, looking at Guillain Barre Syndrome, manufacturing ganglioside antibodies there, and then moved on to a career looking at inflammatory peripheral neuropathies, which has got me where I am today. So the first thing we need to think about is what a paraprotein is. And this is very basic for the non-hematologists here. So a paraprotein is an excess of one antibody produced by the clonal proliferation of B cells. Antibodies, as you know, have this Y-shaped structure with a Fab and Fc portions, which do the work of the antibody. There are light chains and heavy chains, giving the class of the antibody and the light chain. And those antibodies are in different structures, either pentameric IgM, dimeric IgA on surfaces, monomeric IgG, and occasionally light chains which are released separately or occasionally fall off the whole antibody. These can be identified in the serum of patients. The light chains are filtered by the kidney and appear in the urine. The way to detect antibodies and paraproteins in the serum is with a protein electrophoresis, which spreads out the serum across an agarose gel. This produces a densitometric scan, as you can see in C here, with a classical shape. Where a paraprotein exists, there will be an excess of part of that protein electrophoresis, and that can be quantified on densitometry as in C, but using an immunofixation which overlays antibodies to the various components of the immunoglobulins, you can identify here in D an IgG kappa paraprotein. With flow cytometry, you can identify an excess of light chain restricted B cells, for instance, here in E lambda light chain restricted B cells, and you can also identify paraproteinic monoclonal disorders in bone marrow. Paraproteins are pretty common, occurring in 3 to 5% of the population over 50 and up to 8 or 9% of the population over 80 years. In association with a neuropathy, where there is no other cause for that neuropathy, 10% are associated with the paraprotein, and these might or might not be related. IgM is overrepresented in these cases. More than 30% of IgM paraproteins have a neuropathy associated with them. And so overall, this provides the very most basic evidence that IgM paraproteins are sometimes related to the neuropathy that comes with them. So within the whole context of inflammatory peripheral neuropathies, paraproteinic neuropathies form a fairly large group, although individually each is rare. The monoclonal gammopathies that are relevant are MGUS, the monoclonal gammopathy of undetermined significance, or in our case, the monoclonal gammopathy of neurological significance, which is usually IgM and may or may not have anti-MAG activity. Waldenstrom's macroglobulinemia is remarkably common. Neurolymphomatosis, an invasion of the nerve with lymphoplasmacytic lymphoma, is very uncommon. Poem syndrome we'll talk about. Amyloidosis from light chain or even heavy chain deposition, cryoglobulins, and rarely multiple myeloma are all associated with neuropathies. So one of the things to think about when you're deciding whether paraproteins and neuropathies are related is how might those paraproteins cause the neuropathy that you might purport to be related. So neuropathies are either targeted at epitopes, giving very specific clinical pictures. The IgM anti-MAG demyelinating peripheral neuropathy is a very specific disease, which we'll come back to, as is Canamad, as is multifocal motor neuropathy associated with anti-GM1 paraproteins. Sometimes, although there is a paraprotein and the neuropathy is antibody associated, it's not targeted by that antibody, and the mechanism is cytokine mediated, such as in Poem syndrome. Sometimes there's direct infiltration by B cells, as in neurolymphomatosis, which might produce a patchy multiple mononeuropathy. And sometimes there's deposition of either the whole antibody or more normally the light chain, resulting in amyloid and a very typical syndrome of small fiber pain and autonomic dysfunction. Paraproteins can also cause vessel wall inflammation when they deposit as cryoglobulins, for instance, or they can obstruct vessels with cryoglobulinic obstruction or in hyperviscosity syndromes. Rarely, you might have compressive mononeuropathies, either from plasma cell expansions or tissue expansions caused by amyloid, such as in carpal tunnel syndrome or some canal stenoses. And these days, with increasing numbers of therapeutics, treatment-related neuropathies are not uncommon, particularly with things like the first-generation proteasome inhibitors and thalidomide. So the first question to ask is, are paraproteins and neuropathy always linked? And the very easy answer to that is no. Paraproteins or relevant paraproteins can be found in a number of ways. If there's a typical syndrome, such as AL amyloid, you then go hunting for and find the paraprotein, and the neurological consequences of that can be investigated. Sometimes a neuropathy is identified, and then a series of blood tests are done through which the paraprotein is considered. A hematological process such as LPL might be identified, and neurological end organ damage might be sought. And sometimes a clinician may simply find a paraprotein as an accident and then go seeking the hematological and neurological implications of that. Although scenario 1 is nearly always, probably always related to paraprotein, scenarios 2 to 4 can result in misattribution of causation of that paraprotein without care. And the way to avoid that is taking a very careful history, examining the patient and making a full diagnosis, which will tell you if the problem is something else and unrelated to the paraprotein at all. So the investigations we do of the paraprotein to try and get to an answer, first of all, you need to identify the paraprotein. A protein electrophoresis is only about 2/3 sensitive, immunofixation far more sensitive, and occasionally you need to move on to a Bennett-Jones protein in the urine if the serum is negative. Do not ever accept a protein electrophoresis when looking for a neuropathy, because quite often you will not find the low-level paraprotein using this method. Serum-free light chains are really only useful for predicting transformation to malignant clones. Again, identifying low-level paraproteins with a serum-free light chain assay is fraught with difficulties and lack of sensitivity, as quite often the paraprotein is of such low level that it doesn't change either the individual light chain or the ratio of kappa to lambda, meaning that you do not identify it. The light chain, though, is really important and can be identified from the immunofixation, because Poem syndrome is nearly always lambda associated, and anti-MAG neuropathy with IgM paraproteins is nearly always kappa associated. So then other blood tests alongside your protein electrophoresis and immunofixation are a full blood count and differential, an ESR, an LDH, a beta-2 microglobulin, bone and renal profiles, and in the right situation, an anti-MAG and anti-ganglioside antibodies. But most importantly, a friendly hematologist is pretty essential. You might need a bone marrow aspirate and trephine with immunochemistry and flow cytometry, both of which can be extremely useful in identifying what's going on in the bone marrow and what you're likely to be treating in the future. A CT PET might be useful for identifying extra osseous lesions, for identifying abnormal tissue such as lymphadenopathy, and identifying which of osseous lesions might be hot. CSF will be guided by examination in the electrics, as sometimes you have proximal disease that requires lumbar puncture and flow cytometry. And a tissue biopsy of nerve, bone, lymph nodes, or amyloid in terms of skin, fat, or rectum, or the flexor retinaculum, for instance, might be essential to make the diagnosis. Once again, interpretation of all these things requires a friendly hematologist. So how to do it? Well, the first thing to do is to know and revise your neuroanatomy, because the history and the examination that you carefully tease out tells you exactly where the problem is coming from. Is it a distal, symmetrical, small fiber involving peripheral neuropathy? Is it a sensory neuropathy with pronounced vibration loss, but no joint position sense loss and little or no motor involvement in an anti-MAG neuropathy? Or is it a patchy dermatomal sensory loss with some myotomal involvement that might tell you that there is nerve root involved? Know the patterns of specific neuropathies so that you can really make a spot diagnosis. And these are really very simple, and we'll go through them in a second. Also know what is not paraprotein related. So if the patient looks like they've got Parkinson's disease or motor neuron disease and they have a paraprotein, they've very likely got Parkinson's disease or motor neuron disease. Take a classical history and examination and regard the neurophysiology as an extension of that examination, as it certainly informs it. Age is relevant, as if you find a paraprotein under the age of 55, it's very likely to be relevant to the presentation, much more so than in an older person. Target your tests and go where the money is, and have a friendly and knowledgeable hematologist to hand. So I'm going to go through a few simple syndromes now that you can then subsequently recognize. And these are the IgM-related syndromes, and in a little further section, the IgG and IgA-related syndromes. So this flow chart, which has been recently published in Practical Neurology, takes us through the IgM syndromes. And you can see some things here which are not paraprotein related, such as CIDP over here on the left-hand side of the screen. Some small fiber neuropathies, which may or may not be related to paraprotein, and the idiopathic axonal neuropathies down here on the right, again, probably not paraproteinemic. Your paraprotein that you've identified, you then need to classify on the basis of the examination and the electrical studies. And that takes you down one or other of these pathways, whether it's conduction velocity slowing, demyelinating, mixed, axonal, or normal, where you can then think about the different features that you've got in terms of the different tests you're going to do. So let's consider the most common and well-known of these, the anti-MAG paraproteinemic demyelinating peripheral neuropathy, or the distal acquired demyelinating sensorimotor neuropathy known as DADS. This is a chronic progressive sensorimotor demyelinating neuropathy that occurs in older men. It has ataxia and tremor and very little motor involvement. And the sensory loss is the key here. When you examine this, you find vibration sensory loss out of proportion to the other sensory modalities, and usually vibratory sensory loss is up at the hips or even the costal margin with pinpricks stuck within the feet. There's always an IgM kappa paraprotein, very rarely is it lambda, and never is it another pure class. And that paraprotein has activity against myelin-associated glycoprotein, or MAG, and it is felt that that's probably the actual target. There is characteristic neurophysiology and pathology, although frequently you don't get to that. Here is the very typical anti-MAG tremor, which, as you can see, is slightly jerky with multiple lateral components as well as up and down components. That's a very typical tremor of MAG neuropathy. And here is the typical histopathology with demyelination, some remyelination, and widely spaced myelin. This widely spaced myelin results in changes to the neurofilament structure, and that neurofilament structure results in later axonal degeneration, and that axonal degeneration at the late stages means that treatment is not so likely to succeed. So more than 5 years from onset, it's probably not worth treating these patients, as they simply don't get better. Younger patients and patients who are progressing faster are probably those who are much more worth treating. Older, stable patients with long-term disease are not worth exposing to treatment. Another quite well-known paraproteinic neuropathy is the chronic ataxic neuropathy with ophthalmoplegia, M-protein, cold agglutinins, and disilocyl antibodies known as Canamad. And this was originally described in this series of 18 patients by Hugh, Willison, also shortly after me here in this section, with other colleagues from around the world, a lot of them in the UK. The antibodies here are directed against the disilocyl epitopes, that is the 2 sialic acid epitopes that you see in these ganglioside structures here, and seen here on the thin layer chromatography on the right. And this is a very typical picture of patients who are unsteady with ophthalmoplegia and the cold agglutinins found in their blood. Usually there's an underlying monoclone in the bone marrow that requires treating. And very rarely, multifocal motor neuropathy associated with anti-GM1 antibodies is paraproteinemic. And the classical features of conduction blocks seen here on the bottom right and originally described by Alan Pestronk can be produced by a paraproteinemic anti-GM1 antibody. This looks pretty much like multifocal motor neuropathy with conduction block, but it's often in an older population and is slightly more generalized, not like the 40-year-old with asymmetric upper limb weakness. Often the titers of anti-GM1 activity are very, very high, but this gives you opportunities for treatment because multifocal motor neuropathy responds only to IVIG, but if it's paraproteinemic, it might give you the opportunity to use rituximab or DRC, for instance, and therefore looking in the bone marrow here is quite important. Vasculitis with IgM paraprotein and cryoglobulinemias is not uncommon, and this was a 62-year-old lady who was presented to me with a history of osteoarthritis and immobility, who had numb, painful red feet and venous ulcers with pronounced distal motor loss and a pinprick that was equal to the vibratory and joint position loss. But she was referred because she had demyelinating neurophysiology for IgM paraproteins and positive anti-MAG antibodies. But these were the venous ulcers, which are clearly not venous ulcers, and this was the histopathology of the cryoglobulinemic vasculitis that was associated with the very unusual IgM myeloma. So vasculitis occurs with cryoglobulins and IgM paraproteins, worth considering when you look at all the features. The IgG and IgA related syndromes are perhaps less commonly related to the paraprotein, but there are a number of notable syndromes here that should be recognized. You'll see down here that once again we've got some hyperviscosity syndromes that very rarely cause neuropathy, CIDP that can occur in combination with an IgG or IgA paraprotein unrelated to it, idiopathic neuropathies, etc., that are unrelated. So we'll concentrate on these conditions over here on the left. In Poems syndrome, there's a very typical neuropathy that you can recognize. The feet are affected and the hands are affected, but more proximally, there is no involvement. There's often pain. There is conduction slowing affecting the upper limbs and very early and profound axonal loss in the lower limbs. The additional clinical features are important. You should undress the patient, and you find swelling and leak in lots of places, in organs, in the skin, in the peripheries, and in the eyes. And here are some of those features that you can see here, including ascites, bone lesions that can be hot on PET scan, the hemorrhagic papilledema, the skin abnormalities, the increased hair, and these very typical glomerular hemangiomas that occur on the chest. The features of Poems syndrome are noted in the middle here, and you need the typical neuropathy with a monoclonal plasma cell disorder, and then Castleman's, a sclerotic bone lesion, and a VEGF with some other minor criteria to make the diagnosis. Of the key bloods, monoclonal plasma cell disorder, which is always in the lambda light chain, is important. and the VEGF needs to be looked at in that context only. But when you do have that context, the VEGF is nearly always raised and diagnostic. It goes down with treatment with any condition, radiotherapy, stem cell transplantation, or lenalidomide and cyclophosphamide back into the normal range. The diagnostic workup might also include lumbar puncture, bone marrow, PET, an MRI of the brain looking for asymptomatic pachymeningitis, lung function tests, and an echo. Neurolymphomatosis is pretty rare. Here is a man who was sent along with CIDP with a slowly progressive numbness and tingling in his feet, but he has atypical features of shooting pain and cramping, occasional falls, some tinnitus, but importantly weight loss. And this is all based on the background of a lymphoplasmacytic lymphoma with a high level of, in this condition, case unusually IgG paraprotein, but a good response to previous treatment and a mild increasing neuropathy. He was undergoing monitoring, but when he came with his neuropathy, he was found to have conduction slowing and conduction block as here, a paraprotein that had gone up. The MAG was, of course, was negative, and a CSF protein that was raised. And this still was questioned as to whether it was CIDP. But there are 12 white cells in the CSF. And when we performed a biopsy here of the nerve, even though it looked like CIDP in many ways, there were high numbers of B lymphocytes consistent with his previous malignancy in this specimen. This perhaps is a bit more difficult to recognize than some of the other entities, but there should be a high index of suspicion with atypical features and a previous malignancy. And the lesson here is that conduction slowing does not equal demyelination, but a targeted nerve biopsy is key. So in conclusion, the paraproteinemic neuropathies are a diverse group of peripheral conditions which are distinguishable from one another. And in order to distinguish them, you need to know your neuroanatomy, the syndromes and the pathogenesis, basing your diagnosis on clinical medicine. Use the right tests and use them judiciously. Recognize the conditions and diagnose, the ability to recognize them and diagnose them is key to optimal treatment. And most importantly, make friends with your hematologists. If you have any questions, we're very happy to help out here at the National Hospital with these cases. And with that, I'd like to say thank you very much for listening. And if there are any questions, please do ask. Thank you.
Thank you very much, Mike. That was an excellent, really excellent talk covering a huge area. Perhaps I could start the questions. Having been very careful over the years to always check for paraproteins in neuropathies, I have found, perhaps because I've been around a long time, that I probably keep doing it too long. So when you've done your initial screen and it's negative, do you ever repeat? Do you keep doing it? Or is it specific to particular neuropathies that you might have a continuing suspicion?
Thanks, Mary. Yeah, a good question. So in an idiopathic neuropathy where I didn't have another cause, I sometimes, or I try to recheck the bloods after a year, just in case I've missed something. Actually, these days, with the reliable provision of immunofixation, at least where we are, I'm not entirely sure that's so necessary, because the immunofixation is now so sensitive that you can usually detect down to very low levels of paraprotein, and you usually get it on the first go. So I think if you haven't got it with an immunofixation on the first go, then one can think about doing it again. But in the recent years, I don't think I've actually ever found a paraprotein on a second go that I haven't found on the first one, if that makes sense. So keep it in mind. Obviously, if you don't have another cause, then you just have to keep an open mind.
Yeah, thank you. I kind of thought that after many years of not finding them. The question from Hugh Willison, which is, what is the mechanism for altered neurofilament spacing in anti-MAG? And does it occur in other dysmyelinating conditions? An easy Hugh Willison type question.
Yeah, thanks, Hugh. So a lot of that work was done quite a long time ago, and of course Laura Feltry was involved in work around the same time. So there's quite and other people as well, Ron Schnarr and others. So there's an interaction between the axon and the myelin sheath, which involves MAG, and actually that seems to control the phosphorylation of neurofilaments. And neurofilaments all sit together in their network forming that cytoskeleton, and they're kept apart from one another by phosphorylated sidearms. I'm not sure anybody actually knows, has actually completely linked that myelin to axon communication directly to that phosphorylation, but that's how we think it works. And if you interfere with that MAG communication to the axon, phosphorylation is decreased, the axonal cytoskeleton collapses, and therefore you've then got a smaller axon diameter, and therefore not such efficient axonal transport, and therefore subsequent axonal death. So over many years, I think that's why patients then stop responding to treatment, because at that point you've lost any reversibility because you've lost your axons. So it's probably to do with phosphorylation of neurofilaments.
I'm just going to have a follow-up question from Hugh, actually, and then go back to another question. You said, does the MAG knockout have it?
Early on, most of this work was done by Jack Griffin's group, and they did do a MAG knockout mouse and showed that actually there was reduced neurofilament spacing in that. And they also looked at the non-myelinated segments of the nerve proximally right up next to the dorsal root ganglion, and demonstrated that, of course, there was reduced neurofilament spacing where there's no myelin. And of course, there is a reduced neurofilament spacing at each node of Ranvier where there's no myelin as well. It's not as profound as it is proximally. So yes, the MAG knockout does, and also areas where there's no MAG because there's no myelin, you get that narrowing too. And if you look at CIDP in that paper from, say, neuroimmunology all those years ago, CIDP actually, when you just demyelinate a nerve, you sort of partially reduce the neurofilament spacing, not as much as you do in anti-MAG neuropathy where it really completely collapses.
Okay, the next couple of questions. The next one is from Andreas Themistocleous, and he says, with anti-MAG, is there significant slowing in proximal segments, or are the major findings confined to prolonged distal latencies?
Good question. So electrophysiologically, you see most of what's going on proximally, distally, and with the distal slowing. The proximal slowing probably does occur because the blood-brain barrier, blood-nerve barrier is deficient there too. But actually, because the distal slowing is so profound, it's quite difficult to pick out the proximal slowing from where there's much more noise going right up proximal and then right down distally again. So I think the proximal slowing contributes to long F waves that are probably longer than they might be, but actually the distal slowing so predominates that I think that dominates the neurophysiological features.
And then maybe a final question. I'm not 100% sure I get this question. It's from Dr. Zonmali, who says, what can be said about the prophylactic measure of these neuropathies? And I think that's the follow-up. And maybe as part of that, I can fit in comment on MYD88's role in these as well.
Okay, yeah. So, so I think when prophylactic measures, you know, can you stop it? I think that's what the question is. So, I mean, there are three broad categories of people with anti-MAG neuropathies. There are the patients who detect neuropathy and actually they then just don't seem to get worse. They've got a very mild neuropathy and you can look at them for years and they don't change. There's a group of patients who seem to be changing quite quickly. They might be a bit younger. Actually, some of those seem to stabilize off at a lower level, but actually often you've intervened with those. And then there are the patients who are often rather atypical and sometimes and frequently, shall I say, have a different pathogenesis, and they're going down very quickly at the beginning. And so the second two groups, those are the people you kind of would like to be prophylactic with and perhaps treat with single agent rituximab if you can. The reason why, I think Mary's question about mid-88, so the bone marrow, so many of these patients associated with monoclonal gammopathy of undetermined significance. The reason why the bone marrow is important is quite frequently you find very low level lymphoplasmacytic lymphoma or a mid-88 mutated MGUS. You can see mid-88 mutated cells in the bone marrow, and therefore you probably do have a very low level Waldenstrom's phenotype, or you see low level B cell lymphomas, non-Hodgkin's lymphomas with multiparametric flow. And that gives the option to actually treat these patients a little bit more aggressively. And most of the neuropathies seem to occur with patients who have an underlying MYD88 mutation or a low-level B-cell lymphoma. And that then allows you to treat people with more complex chemotherapies, not only single-agent rituximab, but perhaps DRC, or then moving on to other agents such as BTK inhibitors, ibrutinib and things.
Okay.
So although you don't prophylact them, you would only treat them if they needed to be treated. You have to decide which ones you treat.
Okay. Thank you very much, Mike. There are great answers to lots of very good questions. Okay, we now move on to the first Blitz section. These are very short talks of really, current interesting works from more junior people. And the first one has been given by Andreas Themistocleous from David Bennett's lab. Andreas.
Hello, my name is Andreas Themistocleous. I'm going to be discussing a project in which we explored the genetic risk for neuropathic pain in non-freezing cold injury. Non-freezing cold injury is a painful acquired sensory neuropathy seen almost exclusively in soldiers who are exposed to cold and wet temperatures. In 2017, we described the clinical phenotype, which is one of neuropathic pain affecting the hands and the feet of affected individuals. A characteristic feature of this condition is exacerbation of the pain when exposed to cold environments, such as the cold aisle in a supermarket or the fridge. These patients have deficits in vibration as well as pain and temperature. Nerve conduction studies, however, are normal, suggesting intact large fiber function. However, intraepidermal nerve counts are significantly reduced in affected individuals when compared to healthy control participants, showing evidence for small fiber pathology. Soldiers of African descent are disproportionately affected, raising the possibility of an underlying genetic risk. 40 participants were recruited to the NIHR Rare Diseases Bioresource Project, in which we used whole genome sequencing to discover variants linked to rare diseases such as extreme neuropathic pain phenotypes, as well as to study the functional effects of any protein changes. We identified the R185H variant within the SCN1A gene. This gene encodes sodium channel 1.7, which is an important channel in nociceptive function. The allele frequency of the R185H variant is significantly increased when compared to control populations. The variant location within the schematic representation of the sodium channel is shown here. This is an important part of the channel, and previous studies have linked this variant to small fiber neuropathy and increased in neuronal hyperexcitability. However, this variant had not been studied in the context of cooling, so it was expressed in hex cells, and we studied the ion channel activity using patch clamping. The summary of the data is shown in this graph with normalized current on the y-axis and voltage on the x-axis. At room temperature, there was no difference between wild type and mutant variant, as shown through these curves here. However, on cooling, there was a significant shift in the mutant variant when compared to control. This table summarizes the data showing the greatest effects on cooling on inactivation kinetics, with no effects at higher temperatures. This variant at colder temperatures results in increased activity within the channel, which translates into increased neuronal hyperexcitability. In summary, our project has shown a link with certain genetic variants and neuropathic pain in the context of non-freezing cold injury.
Thank you, Andreas. That's an absolutely fascinating story. Can I ask you, when you say it's mainly seen in soldiers, I think that's an ascertainment bias. So do you think if you went to farmers in Africa, and also if it is, do you think there's some evolutionary advantage to people that live in a warm climate, that they have that, and that there's something about them? Have you looked to compare to, say, people living in Alaska, etc.?
Yeah, we definitely saw it mainly in shoulders, but I think we have seen cases where individuals are exposed to cold and wet environments, such as a fisherman. We saw a lady who got stranded. So I think you can see it outside of soldiers and anybody that's exposed to cold and wet environments. In terms of what this variant represents, it's difficult to know what it means in terms of evolution. And I think there would be an element of ascertaining bias. But one thing that we weren't able to do is compare our soldiers to matched control. So these were soldiers exposed to cold and wet environment who didn't develop a neuropathy or neuropathic pain. And I think that would have given us a bit more insight.
And a question from Hugh Willison, who said he saw a furnace worker who overheated his feet every working day for years and got a painful small fibre neuropathy. Do you think heat could do the same thing?
Yeah, I think there's clearly, particularly with sodium channel 1.7, it seems to be a temperature sensitive component because patients with inherited erythromelalgia, they have pathogenic variants in which the heating exacerbates their symptoms, and they get lots of neuropathic pain and redness, and cooling is analgesic. So it's quite interesting that this channel there seems to be an interaction with temperature. So it's plausible that could be relevant. That history of being exposed to lots of heat could cause an injury potentially through a similar mechanism.
But maybe that all of our patients with neuropathy that like to move to Spain for the winter can now get their sodium channels checked.
Yeah.
So with that, I'll hand over to David Bennett to introduce the next speaker.
Thanks, Mary.
Thank you. Thanks very much, Mary, and thanks for the speakers so far. So it's my pleasure to introduce our next talk, which is from Professor Hugh Willison, who's Professor at the University of Glasgow and head of the neuroimmunology group there. And he's done absolutely seminal work on understanding the pathogenesis of Guillain Barre Syndrome, and that's going to be the topic of his scientific talk today. So I'll hand over to Hugh.
Good afternoon. My name is Hugh Willison from the University of Glasgow, and I'd like to welcome you to the Nerve and Neuropathy session, Basic Science Research Talk of the Brain Conference. I've been charged with giving you a background to our research on Guillain Barre Syndrome pathogenesis. My lab has been involved in Guillain Barre research for many years now, and we run a translational cycle of activity through from clinical activity with clinical trials and collecting clinical databases through to biomarker discovery, and have a big program in animal modeling and developing and testing new therapeutic targets. And this cycle has kept us busy in the Guillain Barre space for many years. And today I'm going to focus on some recent developments in animal models of Guillain Barre syndrome, which I hope have informed our direction of travel for development of new therapies and future understanding of pathogenesis. By way of background, I'll remind you all that Guillain Barre syndrome is a post-infectious neuropathy, and the main driver, or the biggest driver that we understand in its entirety is the Campylobacter pathway. I say in its entirety. Clearly there are gaps in our knowledge, but we have a pretty good understanding of what's taking place in this particular form of GBS. And that is that an infection with Campylobacter jejuni leads to an immune response against surface molecules on the Campylobacter, which then activates B cells, probably marginal zone B cells, which then produce autoantibodies against the Campylobacter lipo-oligosaccharide, which cross-react with neuronal gangliosides expressed on both glial and axonal membranes. And the main structure involved in this is the GM1 oligosaccharide, which is expressed both on Campylobacter LOS and on GM1 ganglioside in nerves. And this link, this so-called molecular mimicry hypothesis, is believed to underlie post-Campylobacter Guillain Barre syndrome. Now, once the GM1 antibodies are produced and circulating in the body, they obviously identify membranes which are rich in GM1. And germane to today's conversation, these are very highly expressed in the nervous system, both on axonal membranes and also on glial membranes, including Schwann cell, paranodal loops, and microvilli and abaxonal Schwann cell membranes. And it's at these sites that GM1 antibodies have the potential to bind and produce pathological destruction of the membrane that they've bound through activation of the complement pathway and insertion of membrane attack complex pores into the plasma membrane. So this is the pathway that we think is taking place. Now, it's complicated because GM1 seems to be expressed on both the glial components of the peripheral nervous system and on the axonal components as well. And so GM1 is at the motor nerve terminal on perisynaptic Schwann cells and also at the axoglial apparatus at the nodes of Ranvier, where it's expressed on microvilli, on paranodal loops, and also on the axolemal membrane itself. And when one has GM1 in these multiple sites, it's clearly difficult to identify which GM1 localization is the main pathological driver of GM1 mediated pathology. And this is really where we're coming into this problem. And that is that we have a number of different variants of Guillain Barre syndrome, acute motor axonal neuropathy, AIDP, the demyelinating form, and both of these have been associated with anti-GM1 antibodies. It is appreciated that principally the Aman phenotype manifests with anti-GM1 antibody, but we also get cases of anti-GM1 antibody positive GBS, which appear to have a demyelinating phenotype. And this kind of complexity or interface has led to this concept of the nodoparodonopathy, which is a kind of collection of pathological and electrophysiological states in which it's really unclear whether the nodal axolemma or the glial membranes at the nodes of Ranvier are the primary pathological target which accounts for these distinctive electrophysiological features. And we also have primary axonal degeneration, which occurs in the acute motor axonal neuropathy phenotype, and what we think of as secondary axonal degeneration, which occurs as a result of glial injury. And separating out these various components of GBS, be it a MAN or AIDP or a hybrid form with both primary and secondary axonal degeneration, possibly all of these occurring in the same patient, is clearly quite a challenge. So we've come at this through a very distinctive way in which we have taken mice that lack gangliosides and using these mice as the background, then created transgenic mice which only express GM1 either in their neurons or in their glial cells by hooking up the GalNAc transferase enzyme onto a neuronal promoter or a glial promoter. And this is an example of some anti-GM1 antibody staining, which illustrates this. So that's the wild type staining of the motor nerve terminal at the neuromuscular, just upstream of the neuromuscular junction. And here's a ganglioside deficient mouse, which you can see has no staining at all. And compare that with the neuronal transgenic, which just has the neuronal component stained of the presynaptic terminal. And here is the glial transgenic, in which this spotty staining is actually of the perisynaptic Schwann cells, but with completely absent staining of the axolemal membranes in these mice. And similarly, if we move to the node of Ranvier in these mice, in the neuronal mice, you can see the anti-GM1 antibody staining is very strictly localized to the nodal axolemma, whereas in the glial mice, the staining is present on the microvilli and the paranodal loops, but not on the axolemma itself. So we've been able to produce animals in which GM1 is either present on the neuronal membranes or present on the glial membranes, and then use these to dissect out the different pathways that that follow on from that. So I'm going to just briefly tell you about a couple of experiments out of a very large number that we've done on these animals. And here's a here's an experiment in which we've taken an anti-GM1 antibody and passively immunized these different mice with it over a short period of time. This experiment terminates within 6 hours of commencement. So this is an injury model which produces a very, very acute injury in these mice. And one of the readouts that we use prior to morphological or electrophysiological analysis is whole body plethysmography. And you can see here, I'm not showing videos today because they tend to go wrong in Zoom presentations, but you can see here that these mice have this very characteristic pinched waist indicative of diaphragmatic paralysis. And whilst the paralysis is greatest in the neuronal mice, it is present to some extent as well in the glial mice too. So passive immunization of mice with anti-GM1 antibody in the presence of complement, both in the neuronal and the glial mice, produces a paralytic respiratory phenotype. Now, if we come to look at the pathology within these mice, in the neuronal mouse, we get destruction of the motor nerve terminal. The presynaptic motor nerve terminal completely melts away. And here's a picture of it here in which we should be seeing the neurofilament outline here, and it's completely disappeared. Whereas in the glial mouse, the axon itself is completely preserved, and you can see here is the normal axon, whereas the perisynaptic Schwann cells have been killed instead. So immediately we're able to separate the pathological targeting in these mice to one or other membrane. Now, if we move to the node of Ranvier, we see a rather similar situation, and I've just picked out two targets. I picked out the sodium channel, which is obviously on the axonal membrane, and anchorin B, which is a cytoskeletal protein in the cytoplasmic loops of the Schwann cells. And you can see that the neuronal mouse targets the sodium channel, which is not affected in the glial mouse over this time point, and the glial mouse targets the paranodal loop here with destruction of anchorin B, which is preserved in the neuronal mouse. And so we can use these mice to start to dissect out targeting of different membranes and understand the pathological and clinical consequences of this. And it's very clear that we get antibody deposition with complement activation, with membrane attack complex formation, and complete electrophysiological paralysis if we either injure the glial membrane over this time point or injure the neuronal membrane. And clearly the mechanisms of this are different. These models can be used to test these mechanisms and identify different therapeutic strategies. And we think that calcium flux through membrane attack complex pores is likely to be a common pathway in injuring both these membranes. And we've been testing this, so I'm just going to briefly show you a calcium reporter experiment in which we've used a mouse with a fret indicator of calcium present in its axon, and we can use these mice to measure interaxonal calcium levels. And these experiments are done using multiphoton microscopy ex vivo and in the triangularis sterni preparation. And again, I'm not showing you the videos, but you can see that in the presence of anti-GM1 antibody with the source of normal human serum, you get this big accumulation of interaxonal calcium over time, which is more prominent distally than proximally. And if we inhibit calpain in this model, we don't change the calcium flux, but we certainly neuroprotect. So for example, here is a set of images in which you can see these neuromuscular junctions have disappeared. These are fluorescent mice, and the neuromuscular junctions have melted away. But in the presence of calpain inhibition, the neuromuscular junctions in a separate set of images are completely preserved. So it's very clear that we can use calpain inhibition as a very powerful neuroprotectant of this level of injury, despite the fact that we don't actually alter the calcium flux itself because we don't have an effect on the MAC pores. And so we've investigated a lot of different therapeutic pathways, particularly in the complement cascade, looking at C1q, C2, C5, all of which are very effective in ameliorating these mouse models are being used in clinical trials, and we're particularly interested in calpain inhibition as one neuroprotective strategy, which we're keen to develop over time and are investigating this in a lot more detail. And so I'll leave you with that, and thank you very much for listening. These experiments have been done by Rona, Jen, Claire and Maddie, principally, with a lot of support from other people in the lab, particularly from Deng Gao, who has been making and managing these different types of transgenic mouse. So I'd like to thank you for your attention and leave it at that. Thank you very much indeed.
Thank you, Hugh. That was fantastic. Really nice to see that detail of the role of GM1 in neurons versus glia. So if I can kick off with a question from Mike Lunn, which is, are there clinical calpain inhibitors? Obviously, these might be complementary to the complement inhibitors.
Yes, Mike. Well, calpain inhibitors have been on the sort of therapeutic map for many, many years. I mean, they were used 20, 30 years ago, you know, as neuroprotectants in stroke. So on the shelves of pharma companies around the world, I think there are a lot of calpain inhibitors sitting there. Exactly, you know, how, you know, but they haven't been trialed in the, you know, in the diseases where possibly they might be the most effective. I mean, calpain is, of course, an incredibly important housekeeping enzyme that does all sorts of has all sorts of beneficial functions as well as deleterious ones. And there are many different calpain isoforms. There's a mu calpain and a milli calpain and a lot of different aspects of calpain biology. So the answer is yes, I think there are. The devil is in the detail, of course. But I do think that in these acute calcium-driven destructive processes like Aman, for example, that there really is a bigger place to play, a bigger place for calpain inhibitors than has been recognized. And whilst they might not be effective in stroke, for example, I would like to see us nudge our friends in pharma to go into their sort of storerooms and pull out a range of calpain inhibitors which have been developed for us to test.
Thank you. Just very quickly, because we've only got a few seconds remaining, but there's a lot of interest in inhibition of Wallerian degeneration. I have a feeling that probably wouldn't work here because I think that's upstream of the calcium, but I just wondered if you thought there was any role as companies are trying to develop inhibitors of that pathway.
Yeah, I mean, we've looked at WLDS and SARM, for example, and no, this is down from there. So, so no, but having said that, in the axonal degeneration that eventually follows in the demyelinating mouse, yes, there may be, but not in the acute axonal injury. But a very good and important question, and of course we've looked.
Great, thank you, Hugh. That was wonderful. Thank you very much. We better move on to the next session now.
So the next last talk is the clinical translational research talks, and I'm absolutely delighted to introduce my very good friend, Professor David Adams from Paris, who is internationally leading in the TTR amyloid field and actually has been pivotal to almost every clinical trial coming into practice over the last 10 years. And it's particularly nice to have a talk on a genetic neuropathy as a talk in translational medicine that has been translated to therapy. Thank you, David.
Good afternoon. I'm very happy to participate to the brain conference and the neuro and neuropathy session. I My talk will be focused on therapy for TTR amyloidosis. Here are my disclosures. TTR amyloidosis is a multisystemic disease to amyloid deposits and diffuse innervation. Main manifestations are sensory neuropathy, autonomic neuropathy, and also motor neuropathy. But also cardiac manifestation, ocular manifestation, or renal manifestation. The various inaugural and non-specific manifestations explain several misdiagnoses. Translational amyloidosis are disease of adult onset with autosomal dominant transmission. Translational or proalbumin is the amyloidogenic protein with tetrameric conformation and 4 identical subunits. It's mainly produced by the liver, choroid plexus, or retina. The role in transport of thyroxine and retinol binding protein. In the 1980s, it was considered as an endemic disease in Portugal, Sweden, and Japan, but it's now considered as a worldwide disease. To improve diagnosis for this rare disease, an expert consensus recommendation have been established in patients with early onset with usually positive family history. For those with late onset, we should suspect in case of progressive axonal sensory motor neuropathy or atypical CIDP plus one of the following criteria, including autonomic dysfunction, bilateral carpal syndrome, or some systemic manifestation as weight loss. 2 key tools for diagnosis are detection of amyloid deposit by biopsies or cardiac DPD uptake and scintigraphy, or TTR gene sequencing to identify one of the so many amyloidogenic variants. There are more than 100 variants of TTR gene. Predominant clinical manifestation, neuropathic or cardiac, depends on the genotype. As an example, ILO 122 is a cardiomyopathy, V30M is a purely polyneuropathy. ATTR amyloidosis with polyneuropathy are severe progressive disease. One of the main impacts of the disease is gait disability, requiring aid for walking earlier in late onset V30M variant. After onset, delay to walking difficulty range between 2 to 3 years and require aid for walking 1 to 2 years later. Survival after onset is short, around 7 years. The overall management of ATTR polyneuropathy is complex. First, you have to stage the neuropathy and also the systemic amyloidosis for the sensory motor autonomic neuropathy and also for cardiac, renal, and ocular manifestation. Then you have to propose therapy, including symptomatic therapy, anti-amyloid therapy, and to manage organ involvement. Genetic counseling is crucial to detect carriers with TTR gene testing, to propose close follow-up for detect early the disease. This disease requires multidisciplinary approach. This is another view of therapeutic strategies developed during the past 30 years. Liver is the main target of disease-modifying therapies. The first proposed was liver transplantation, able to suppress the main source of mutant TTR. More recently, TTR silencers were proposed. There is a project of in vivo gene editing. The second target was circulating tetramer of TTR in the serum with TTR stabilizer, tafamidis, and the last target are amyloid deposits with anti-TTR antibodies. In the 1990s, first liver transplantation allowed to reduce dramatically mutant TTR in the serum for the first patient operated. Both clinical and electrophysiological impact were encouraging for the first patient operated with stability, but not at later stages. This procedure has been generalized over the world with more than 2,000 cases. The success is clear for early onset V30M, as you can see on the blue line, doubling survival, but just in another variant and late onset V30M. The risk factors have been identified: non-V30M, advanced disease with severe neuropathy or cardiomyopathy. CHES was due to accumulation of wild-type TTR in late onset after liver transplantation. Tafamidis, the TTR stabilizer, was able to bind to the site of thyroxine to avoid dissociation in monomers and dimers which form amyloid aggregates. The phase 3 trial enrolled patients with V30M TTR. Patient received tafamidis or placebo. Primary endpoint was NIS lower limbs response of less than 2 points change after 18 months. This study showed that tafamidis was able to slow progress of the disease, and tafamidis obtained marketing authorization by EMA in stage 1. Here are the long-term results of tafamidis in V30M variants. The baseline severity is important to predict long-term response. Those with NIS score higher than 10 or low concentration of TTR in plasma or male gender are non-responders. As a TTR giant silencer, RNA therapy had a double challenge. For the first one was to target liver by lipid nanoparticle formulation in a frustrated antigen in the liver. The second one was to knock down production of both mutant wild-type TTR with a synthetic siRNA incorporated in a multiprotein complex called RESC, the release of the sense strands to direct the activated RESC complex to the target mRNA of TTR and to stop synthesis of the specific mutant and wild-type TTR. Here are the results of the phase 1 trial with TTR01 RNA therapy. This trial enrolled patients with TTR polyneuropathy. After 1 milligram per kilo of TTR01, obtained reduction by 80%. After one IV infusion of TTR01, it was obtained for both mutant and wild-type TTR. After the success of the phase 1 trial, phase 3 trial was designed comparing patisiran to placebo group in a large cohort of patients with various severity of the disease. The primary endpoint was change from modified NIS+7 of a composite score for the neuropathy, and many secondary endpoints to assess the walk, the disability, and autonomic dysfunction. 225 patients were enrolled in the trial, usually at a late onset 60 years old. Most of them were male, 3/4. Enrollment was balanced for V30M or non-V30M, stage 1 versus stage 2, and cardiac involvement as baseline. Here are the results of APOLLO trial. Success with a rapid, major, persistent TTR reduction in the serum all along the trial for those receiving patisiran. Primary endpoint was reached with a clear difference between the course of modified NIS+7 at 18 months for those patisiran and placebo, and surprisingly a reduction of modified NIS+7 suggesting reversal of the disease for those receiving patisiran. It was also the same impact on the quality of life. Interestingly, improvement of autonomic dysfunction, gait speed, and stable disability at 18 months. The safety of patisiran was excellent. No deaths related to study drug, no safety signals on hematological, hepatic, or renal functions, The two main adverse events were infusion-related reaction and peripheral edema. The one-year open-label extension confirmed the long-term effect of patisiran and also confirmed the impact on the placebo group of Apollo trial. There is another approach of TTR gene silencing with antisense oligonucleotide notasen with a similar clinical trial with notasen or placebo and 18 months treatment. The NeuroTTR trial, which assesses antisense oligonucleotide and notasen, was also positive. Change of undefined S+7 and quality of life at 18 months versus baseline were positive as compared to placebo group. As you can see, notasen led to dramatically slow progression of neuropathic score and quality of life, some safety signals, risk for thrombocytopenia and glomerulonephritis. 2 years open-label extension of NeuroTTR trial confirmed the impact of inotersen on disease progression with slowing progression, a major TTR knockdown after introducing inotersen in placebo group of NeuroTTR trial. There are some difference for these two TTR gene silencers. Specific targeting for the liver for patisiran by more diffuse distribution for inotersen, the way of administration IV every 3 weeks for patisiran or subcutaneous every weeks for inotersen, the monitoring for platelets every 2 weeks for inotersen, the safety with risk of thrombocytopenia or glomerulonephritis with inotersen or infusion-related reaction for patisiran, the slow progression with inotersen or some improvement in patisiran, and both therapies received marketing authorization by EMA and FDA for FAP1 or FAP2 stages. This is another view of accessibility to disease-modifying therapy over the last 30 years. As you can see, before 1990 there was no therapy for this patient, and the first one was liver transplantation, and since 10 years different clinical trials allowed to obtain marketing authorization for tafamidis in 2012, and patisiran and inotersen TTR stabilizer in 2018. There are many perspectives for ATTR amyloidosis. Clinical trials are ongoing to assess new generation of RNA and ASO formulated with GalNAc that allows to target liver by subcutaneous injection and to space the injection by 1 to 3 months. There are also ongoing RNA and ASO therapies on amyloid cardiomyopathies. There are new approaches with anti-TTR antibodies or in vivo gene editing. There are also new biomarkers for early onset monitoring for disease progression. A very exciting approach is in vivo gene editing to cut with CRISPR-Cas9 the gene of TTR. It's an interesting preclinical trial in the monkey showing the TTR knockdown during a 1-year period after 1 IV infusion, and the first 6 FAP patients showed interesting results at 0.3 mg per kilo in the phase 1 trial. TTR amyloid polyneuropathy was supposed to be the most severe hereditary neuropathy of adult onset until 1990. It's a worldwide disease which may be easily diagnosed by new clinical criteria, genetic testing, minimally biopsy or DPD scintigraphy. Genetic counseling is crucial for close follow-up of carriers, and most patients have access now to disease-modifying therapy, TTR stabilizer at very early stage, or TTR gene silencing.
Thank you very much, David. Very excellent talk and a very exciting time in treating TTR amyloidosis. As you know, in the UK, our commonest mutation with neuropathy is the ALA60, the Irish mutation, and they present later, and actually they often have heart involvement, and often death is 3 to 5 years, is much quicker than some of the earlier variants. So I agree completely. Maybe the first question I'd have, in real life, since we've started using the therapies, when we measure TTR knockdown, there does seem to be some variation between patients. And at least I get an impression of a response to therapy, correlation with the knockdown. Have you had a chance to look at that in real life with your patients to date? Because that would probably become quite critical when you look at the AL amyloid story.
Yes, I agree, because the overall study of Apollo shows that there is no impact on the TTR knockdown on the course of the disease after participant. And in my patient, I had some example of progression in spite of TTR gene silencing, and there was a still high TTR in the serum. So and we had a recent case. There is no TTR knockdown for one patient who received C6 infusion. So there is some discrepancy from one patient to this, and I think the challenge for the next is to pay attention to some biomarkers, as you say, for TTR, and some one are good recipients. And I think it's very interesting because we can monitor very closely these patients to say if we have to pursue the treatment or switch, and to have to, we need other than plasma neurofilaments in the light chain in the serum also would be another one. So this is the next challenge to manage with new exciting therapies.
And maybe a second question I'd ask, I mean, it's a slightly difficult question, but at the moment, particularly in the non-endemic people, they turn up with disease. I know we have a fellow here from Portugal who is so used to seeing people really early now because they're in big families and they treat them early. So if you have established disease, perhaps particularly cardiac disease, and you gene silence, we know there's also resorption of the amyloid. So we know the amyloid load goes down. Do you think, I mean, I'm surprised in a way we haven't seen more sudden cardiac death or cardiac complications if you take a mass of tissue away. Have you any, do you think that might be a future problem from a heart perspective, from treatment? Just thinking mechanically that you've got lots of stuff in the heart wall and it gradually resorbs. It feels to me, a potential problem, but I have no idea.
We have some variant like tyrosine 77, like LA60 in your country, who have mixed neuropathy, and we have some who received the TTR silencers since many years, 5 or 6 years, and the thickness of the cardiac septum didn't decrease anymore from 15 millimeters.
Sure.
6 years later, the same, and they are alive. So I think you have the same impact on stopping progression for the neuropathy from one side and the cardiopathy also. And I think you have the same impact to the nerve and to the earth. It's the same war.
Sure. Okay, I think that's interesting then, because
it may make us
a bit more careful in future about adding in, because there's all this question of additive therapies. Because I would wondering. Any other questions? I mean, the big thing, David, now that I have an opportunity, is having seen, this week actually in clinic, I have a very badly affected 20-year-old who has a very unusual mutation, which is CNS predominant, that started at age 16. She's now encephalopathic, dementing, multiple seizures, neuropathy, cardiac involvement, a very severe form of it. And of course, the gene silencers don't carry the blood-brain barrier, don't cross it. Tafamidis does a tiny bit. I mean, entacapone and talcapone may be something that'll be interesting for that. But at the moment, I don't think there's anything effective for the CNS. I mean, have you seen any of these patients or found anything to be effective for the CNS amyloid we get with the other 15% of the TTR?
I read a paper about talcapone suggested to be used for this spatial phenotype. And we have also cases late onset who develop late 20 years after liver transplantation, some CNS involvement. So we are. But I think Nine is working on a intrathecal injection of another form to target the CNS. So it's not ready now, but maybe in the future. But this is a big deal.
No problem. Excellent. Well, thank you very much, David. And just thank you to all the speakers. Fantastic today. I'm just going to hand over to David to close the session. Thank you.
Yeah, thank you. So, well, thanks for co-chairing, Mary. Thanks for all our speakers. It was a wonderful series of talks. And thank you to everyone for listening. I think the future is bright for peripheral nerve research and management of peripheral neuropathies. We've seen better understanding of inherited inflammatory neuropathies and excitingly gene therapy coming to the world of peripheral neuropathy. So I think it's been a really positive session, and thank you very much, everyone.